So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the localization assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online event hosted by the National Neonatology Forum, Gujarat State Chapter. And the focus of today's session is lessons from expert antibiotic stewardship in NICU. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Ahia sir, the Honorable Secretary of NNF Gujarat Chapter, to start the event today with his enlightening words and for the further coordination. So the rise is all yours, sir. Please proceed.
Yeah. Thank you, Ritu. So it is a great pleasure to invite Dr. Maulik sir, who is an academician, excellent academician, and you must have seen his superb clips on YouTube also. He is providing lot of information on the YouTube channel for us. So it is a great honor to have you, sir. So before starting the session, I would invite Dr. Shwetal Bhatt ma'am, who is the president of NNF Gujarat State Chapter, to say a few words.
Thank you so much, Dr. Kunal. It's indeed a pleasure to have Dr. Maulik with us as an expert. This is one of the best, the topic which is very much essential in this antibiotic resistance era. And so I had heard him with this topic at Dharampur. I thought of that our NNF Pathshala viewers also can get benefit from this topic. So within 2 days, I could convince Dr. Maulik for delivering this expert talk. And I'm very thankful to Dr. Maulik for immediately accepting the invitation and sharing his expertise and whatever research he has done on this topic. It's really amazing to listen. Thank you so much, Dr. Maulik. Thank you. I would like to ask Dr. Jatin to please introduce the Dr. Maulik, sir.
Hello.
Yes, Jatin, you are audible. Jatin? Jatin, you got muted.
Hello. Yes, sir.
Yeah.
Yes, sir. Please share
the screen
now.
Now I'm audible.
Yeah, Jatin, you are audible. Yes.
Okay. Good afternoon, everybody. I think Dr. Maulik sir needs no introduction. He's amazing teacher and a wonderful learner too. He's constantly updating his knowledge and has got special interest in neonatology since his PG curriculum. He has done his fellowship, neonatal fellowship, couple of years back, and for last 20 years almost he's in teaching field. He's made many doctors, and I met him personally many times. But the way he reacts with colleagues and students are really happy with them. So he is very amazing personality, and we'll be very happy to learn very special topic for NICU, which is infection control. Over to you, sir.
Okay.
Maulik, sir?
Yes.
Yes, sir.
Am I audible?
Yes, sir.
Okay. So here we go. I'm starting the presenter view. Okay. I hope it is now on the screen, right? I'm sharing my screen.
Yes.
And that is visible to all of you.
Yes.
Ultimately, we all know that the antibiotics are going to be a crucial weapon for every one of us who is working in NICU and taking care of those tiny ones. So most of the times we all know that the weapon which is used most often is also abused also most often. So that's why antibiotic stewardship is required. And this was one of the patient which was been referred to us from a peripheral center, and I was shocked to see that all the antibiotics in my armamentarium were been found to be resistance, and the antibiotic which were sensitive were tigecycline, phosphomycin, something which I read or heard years back, have come back into the picture. So that made me very nervous what to start. Our own NICU again figured out one more baby, which was also being found to be having a bug, which was sensitive only to imipenem, meropenem, or atrapenem. So that was a thing which will give us all of us a nightmare, specifically treating such baby, because when we do not have any weapon to use against the bacteria, we feel so helpless. That's what the feeling we all carried throughout the COVID pandemic. So, since we are talking in Saurashtra and Gujarat, where usually 3 to 4 is a time to nap, so to keep you all awake, I'm having this particular quiz question for you. So, which is the last antibiotic discovered? Everyone knows that penicillin was the first antibiotic to be discovered, but which was the last antibiotic which was discovered? Can anyone guess? Well, just to since the time is very short, it was tixobactin which was been last discovered, and after that there are no antibiotics been further discovered. So many of us might wonder also. The gentleman on your screen is Alexander Fleming, who invented penicillin, and years back, 50 years, 60 years back, he only said that even penicillin, which was the first antibiotic of the world, was also possible to generate a resistance amongst the microbe, because when the drug is been exposed to the bacteria, or the bacteria are rather exposed to the drug on a lower concentration, these microbes learn how to come up from the bacteria and prevent themselves or survive themselves. So that was the idea. And antibiotic resistance often happens. We all know it's a fight to survival, and the survival of the fittest remains to be the law of the land. Hence, the bacteria also try and evolve over the period of time to resist against these antibiotics and prevent their own existence in this world. So out of lot of bacteria, usually what happens is one bacteria finds the trick to break the shackles of the antibiotics, and that particular bacteria is there. But these are in very, very, very minute number and minute percentage, and often they do not grow over a period of time, or that resistance which has been learned by one bacteria is not transferred so fast. But what happens is we often choose and abuse the antibiotics. So all the good bacteria, for example, when we use a penicillin group of antibiotics or a broad spectrum antibiotic, it kills the good bacteria as well as the bad bacteria. But when the bad bacteria are killed, along with that, if the good bacteria are killed, there is no more resistance left for this particular bacteria who has learned how to kill the antimicrobials. So ultimately, the bacteria which is resistant now finds a fully open ground to play with, and they usually tend to generate and grow further and further. And when such things are occurring, usually this resistance is further transmitted from generations to generations of bacteria, and ultimately the end result is antibiotic resistance bacterial family or society together. So ultimately, if we see the history and look at the timeline of antibiotics, we find three different eras of pre-antibiotic, antibiotic, and post-antibiotic era. Mostly, we have seen that in the pre antibiotic era, before the birth of the penicillin, usually there were a lot of infections and people got killed because of the infections, and we have no answer to that. Suddenly, we came across with antibiotics. Fleming got the invention of the penicillin, and then lot many antibiotics have been discovered in the next 50 years. And this was an antibiotic era where we discovered that we have sort of a lot of weapons to fight against these bacteria. So ultimately, the death because of the infection reduced. And after that, what we are going to face now and in coming next 20 years is going to be post antibiotic era, which is really going to be dreadful, because there will be a lot of infections. Many of them will be a multi drug resistant bugs, and we will not have our own weapons like we had rather in the antibiotic era, and ultimately we will be feeling helpless. So that is something we need to think about. Here the point is, somebody has predicted that today, even though in this era where we are trying to improve, 7 lakh deaths are occurring annually due to multi-drug resistant bacteria, or antimicrobial resistance leads to killing of so many people across the globe even today. And it is predicted that by 2050, a few years down the line, we will be seeing 1 crore death because of the antimicrobial resistance or multi-drug resistance bacteria. Then if we see this particular graph which I got from the Lancet, which is having a comparison of different statistics available from the various countries, by in which neonatal death because of the sepsis has been described, we may feel that India is on the top of this particular graph, but very sadly top of the graph, because this is a chart which is representing the neonatal sepsis death caused by the bacteria resistant to first line antibiotics. Means India is already topping the chart of the antimicrobial resistance. Number of antibiotics which have been invented in this particular few years, if we see from 1911 to nowadays beyond 2024, then we will find that initially there were a slow, steady progress towards the 50s in the 1950s, 1960s. Gradually, in the years of 1980s and 90s, we had plenty of antibiotics getting discovered. But look at the 2018. This is the number which worries me the most, that we do not have antibiotics nowadays getting discovered, and that leads to the statement of the WHO, who says that only 27 antibiotics were there in the clinical trial phase. Mind well, if you are in just a clinical trial phase or a development of antibiotic phase, that does not mean this antibiotic will come always for use. There may be some innovation, there may be some drawbacks or the finding that antibiotics do not work or they might be harmful. So ultimately, we will not have all these antibiotics. Only 12 new antimicrobial drugs have entered since 2017 to 2021. And again, more worrying factor is this. See, what happens is let us understand this with the help of an example of a software. Suppose you buy a new software for your own work. After a few years, this software will be found to be older, having some bugs, some viruses to tackle, and there will be a lot of problems. So what companies do is they update the software or send you a key which helps you to update your software, and ultimately you overcome the routine bugs which were been troubling this particular software. But this is not the invention of a new software or new class of things which will help your or augment your workflow. So here also in antibiotics also, when we find that this particular bug is taking on the antibiotics or getting resistance to antibiotic by a particular mechanism, then we try to overcome that mechanism. So this is something like in the market of washing powder, what we say is Rin to Naya Rin Supreme. The antibiotics nowadays also just overcoming that particular last mile or the last step of the antibiotic chemical formulation that will overcome that particular bugs today's resistance. But there is less and less number of new class of antibiotics are getting invented. That means that suppose penicillin is a class of antibiotic, macrolide is a class of antibiotics. So a bacteria which is resistant to penicillin might still be sensitive to macrolide. So if we go and find new class of antibiotics, definitely we have a more edge over the bacterias. So ultimately, we need to find new class of antibiotics, and that is not happening. What we are doing is Rin to Naya Rin Supreme. So ultimately, we are lagging behind in this war against the bacteria or the antimicrobial resistance. So, and the another problem which leads to this again is because most of the pharmaceutical companies, they often look at the cost and benefit ratio. If I'm going to find out or invent a drug, lots of my effort will go into the research and development of that particular drug. If that particular drug works for me on a lower ground or it might give me a lower benefit, I will definitely not go for the R&D. If you take the drugs which are there for the BP or diabetes, these are the drugs utilized for lifelong purposes. So some company would definitely choose to take over the BP and diabetes research and development but not in the case of antibiotics, simply because antibiotics will be utilized for a lower number of days, or 7 or maybe 14 days. But then after what? So ultimately, companies are nowadays losing their interest in the R&D of these antibiotic drugs, and that's one of the reasons that we are not getting the newer antibiotic class of drugs. As per the WHO data from the July 2022, these many drugs are under the clinical trial sessions, and very likely that few of them get marketed and will be available. But that number, if you see on the last row, that on the green, is very, very few. Even 86 drugs enter this particular cycle, but only 5 come to really market. So that takes us to again a wake up call. What is ESBL? So there are the 4 options in front of you. I'm putting this sort of KBC slides in between just to keep you awake. So ultimately, the ESBL is extended spectrum beta lactamase. Most of us know about it, just to keep a wake up call. This particular graph is really something we need to look at, because here we are seeing that the drugs or the multi-drug resistant organisms are getting increased day by day. From 2018 to, if you see in the 2020, the beta lactamase inhibitors or the common drugs what we use are in getting resistance, and resistant bugs are getting discovered. In the same hospital, this was a 3-year observational study. They found out that the multi-drug resistant organisms were on the rise. You can see the MRSAs were on the rise, ESBL Klebsiellas were on the rise. And remember, these are the same bacteria which are killing our neonates. So ultimately, what's happening in front of us is more we use, rather we abuse, and more we lose our antibiotics. We have encouraged the evolution of drug resistant bacteria faster by using left, right, and center all the antibiotics we know or we can prescribe. So ultimately, what do we want in the long term against this war against the bacteria? We want to use our drugs for a prolonged period of time, and we want to reduce the burden of resistance till we find out a new antibiotics which serves again for next 25 to 50 years. So for that particular time purpose, we want to prolong the use of the available drugs which are really working for us. So what's antibiotic stewardship? In a proper meaning of the stewardship means something like चौकीदारी या कारभारी कहते हैं जिसको. तो अल्टीमेटली हमें चौकीदार बनना है, हमें एक गार्ड करना है हमारी एंटीबायोटिक्स को. यहाँ पर हमें 2 चीजें करनी है. वी अल्टीमेटली नीड टू डू to improve. Number 1, right choice of antibiotics, whether we need antibiotics or not, that is the first question. Then we need to decide which is the right choice of antibiotic for that particular situation. Then we should choose the appropriate dose, then the duration and route. And that cycle has to be again repeated by an observer, observing that how well this particular unit or that particular person is using the antibiotics, taking off all the norms into play. So this is what in the simpler terms called antibiotic stewardship. When we do antibiotic stewardship, we have plenty of advantages. Number 1, we have better outcomes. The baby's survivals do increase and the unit also gets a happiness. There will be lots of reduction of the drugs, and as we reduce the drugs, we also reduce the chances of toxicity and side effects of those drugs. Since the antibiotics are now lesser and lesser used, ultimately the burden of cost also gets reduced. So baby is happy, baby's parents is happy, pediatrician is happy, and the neonatologist is happy, and the country is happy. And lastly, we will not generate resistance further, so we will be able to utilize our drug for prolonged period of time. Then our outcomes will be really improved. Here we can have these archives of disease journals article in front of us that shows that there was a measurable improvement in the reduction of antibiotic use and especially use of the broad spectrum target antibiotics. So that's really something which is proven. If we see at this particular chart, it shows that once a particular unit has taken up this antibiotic stewardship, their antibiotic utilization rate drastically reduced at least 30%. So that is really going to help a unit by saving the antibiotic days and early discharge of the baby also at times. Then if we see this particular chart, here you can see that in 2012 they did not had the antibiotic stewardship, but then later on they found out that antibiotic stewardship program helps. So they were quarterly measuring these particular things, and you can see just in 2 years the antibiotic utilization has reduced drastically, and we can see that the graph has come down, and the use of the broad spectrum antibiotics as well also has come down. Here we can see that different authors who have investigated a particular unit in a pre-antibiotic stewardship area, which has been drawn here as a blue. And when we see the pink chart, that is a post-antibiotic stewardship program application, the difference is very much evident in front of us, that the pink chart shows that there is a gradual reduction in all these particular units, and they have really achieved at least 30% reduction in their antibiotic usages and also the outcome. The same thing also we can see here when we apply this particular to a premature infant's uh, utilization of antibiotics in NICU. Here also you can see that post antibiotic stewardship program, we have a drastic reduction in this particular thing. And this is really remarkable simply because we all know that premature baby is already struggling with so many of problems. And if we reduce at least one of them, we'll be very happy. And if we can reduce the antibiotic use for that particular duration, really we all be happy and babies will be blessing us. Again, we can see here that the antibiotic stewardship program leads to reduction in the antibiotic days and the reduction in development of the multi-drug resistant bacteria or organisms. So ultimately, antibiotic stewardship program has three pillars. Number one is a national level policy. Number two is a regional observership or a state level observership. And thirdly, a particular hospital run program on antibiotic stewardship. WHO has been really proactive in this particular thing. You can see and download this particular document, which is available free on the internet. And there are various objectives which have been laid down by WHO, which we can utilize for serving out the antibiotic stewardship program at our hospital or at our community. Our own NNF, the National Neonatology Forum, also supports the antibiotic stewardship. They've got many recommendations that every neonatal unit should ideally have an antibiotic stewardship program, and it should be very well monitored and reported back to the state and the national bodies so that the feedbacks can be further analyzed and a national level policy can be improved or displayed to all of us. Even our own MCI or the Ministry of the Health and Family Welfare has also spotted out this, that the antimicrobial resistance is on the hike. So we all need to be very cautious when we write antibiotic prescription. So what are the national level tasks? Suppose an NNF like body takes up the program of antibiotic stewardship, what they can do? So they can do an education and awareness program for all of us. They can plan and strategize how and when or which antibiotics to be used in a which particular situation and teach all of us. Then they can produce certain supporting technology which can help us out in particularly the assessment or monitoring of this particular antibiotic resistance. Then they can also put up the regulation and guidelines of these particular antibiotic stewardship programs, and they can monitor it. So again, a wake-up call for all of you. The KBC question for you is, which organism is responsible for the early onset sepsis? I'm sure everyone knows that this is Listeria monocytogen. Though nowadays in our units we are not able to cultivate it back. Maybe some Indian culture statistics might show different, but just a wake up call. So if I'm a neonatologist, what should I do to apply the antibiotic stewardship program at my hospital? Well, there are 7 pillars in this particular thing. The easier way to understand this is that antibiotic stewardship program is everyone's game, because the babies do not bring bacteria to the unit, especially when they are been admitted within our unit after the birth. Then who brings the bacteria to the baby? Yes, all of us. So ultimately, those who bring bacteria or start antibiotic need to work upon antibiotic stewardship program for sure, so that we can survive many babies. We need to have a leadership commitment, especially at the level of director or dean or principal level, so that they can form up a team, they can provide them time and resource to work upon this particular program. They should have a regular SWOT analysis, meaning strength, weakness, opportunity, or threat identification in this particular area of the practice of neonatology. And they should strengthen the area which are really weak and might not be performing well. So that's why we need to have a good leadership commitment. And last part of that is they should get a feedback report. And after the analysis of the report, the strategies should be reformed and utilized. It's an accountability ultimately required. Stewardship rounds should be done for the NICUs if it is a bigger hospital or a medical college, and it should be specifically targeted towards implementation of policy rather than the fault finding exercise. We should have a regular assessment of the antimicrobial resistance and antimicrobial utilization of particular unit. Why within this month the ceftazidime was been higher utilized, why imipenem was required this week. That all should be investigated properly, and then only we can come to know that what is wrong with our policy and where we are really buckling down in front of the bugs. And finally, if there are some issues which have been requiring troubleshooting or the problem solving, we should be helping out that particular thing. WHO has again came to rescue, specifically with the antimicrobial classifications. They have said it an aware classification. Let's understand what is aware classification. That is a short form or the acronym of this particular name. They divided the drugs or all the antimicrobials available into 3 different groups. The first is which is should be accessible to all. We all know that all the countries in the world do not get equal opportunities to use antibiotics, neither they do have the stocks to utilize. So ultimately, first line or the drugs which should be really accessible to all the countries and all the neonates, that is the first. Second line or the drugs which are to be used watchfully is in the second group, watch. And the third one is those groups of the drug which are really to be kept reserved and to be utilized occasionally and when it is really warranted. So these are the Excel sheets or the list of antibiotic which has been available in front of us. There are 88 antibiotics presently in the, when I assessed this particular list in 2024 January, there were 88 first line antibiotic or first choice antibiotics which have been there. Many of these drugs might look very old to many of us, but still they work. Just like for an example, ampicillin and amikacin or ampicillin and gentamicin still works wonderfully well. And most of our NICU units do have that first line antibiotic policy as them. Not only that, but we should also ensure as a global citizen that all these drugs are at least available to all the countries who take care of the neonates. Then the second line drugs is the drug which are to be limited for a specific infection. For example, I'm targeting a particular infection which is gram negative, where I need a CNS penetrating drug. My choice of drug would be definitely cephalosporin third line or third generation, and that should be my choice. So this is an infection specific, requirement specific drug which is used often as a second line when your first line usually do not succeed, or you find a specific indication for utilizing these drugs, we should be stopping and really re-evaluating our diagnosis also here, because many a times those who are non-septic babies also receive this in the name of sepsis. So we need to be always vigilant on this particular aspect. Last is the reserved for the MDR infections. If there are multi-drug resistant infections erupt in front of us, these drugs are going to salvage us. Remember, we have only 28 drugs here, and many of us might be laughing to this class that, oh, we are already using this. We are already starting this as a first line, but this is not a pride moment for either of us, because we are losing these drugs by overusing and abusing these drugs. And when really a doomsday will appear, we will not have antibiotic to fight against that particular bug. So again, which biomarker has the highest sensitivity? Can you tell me? This is a question for 5 lakh rupees. And 5 lakh rupees will be paid by NNF Gujarat. So this is the biomarker. You may have issues of the timing and temporal correlation of this, but this was just a wake-up question. So let's get back to our business, that why NICU prescriptions are so difficult and there are so many stringent guidelines we have to see. The reason number one is it's a diagnostic challenge. We do not have much of the clinical data to support that, yes, this is infection only. And many a times the infection signs which are really proving that it is infection are often late, to the extent that we might lose the baby. So there are a lot of biomarkers and other things are available, but still we often struggle because many of them might not have sensitivity, many of them might have issue with specificity, and we struggle to diagnose a newborn with sepsis. Then our answer comes that culture is the gold standard, but remember, cultures are also remaining, the yield of a culture would also be 40 to 60%, and we do not have a short answer often. And we all have seen that there are culture negative sepsis, which is might very often encountered in the NICU practice. Early onset sepsis still remains to be an enigmatic area, because many times we have seen that there will be chorioamnionitis but no newborn sepsis, or a culture which is really dry and not yielding anything to us. So early onset sepsis diagnosis is still elusive, but still leads to most of the antibiotic overuse and abuse. So this is something we need to work upon. Then our antibiotic prescriptions are also difficult because there are lots of pharmacokinetics and pharmacodynamic related issues. The preterm babies having kidneys not functioning as well as term babies. So reduction of the dose, we have to monitor the drug levels, and also on the back side of that, we are worrying that if my antimicrobial level will be reduced to such an extent, the bacteria will not respond to it. So it's a very tricky situation for a neonatologist, especially when they are prescribing the antibiotics in a right dose in the premature sections, or especially those baby who are having compromised kidney functions or other things. Late onset sepsis also present in variable presentations, and we also struggle often to find out which is the right choice of antibiotic for this particular situation. So if I want to implement the antimicrobial stewardship in my NICU, what should I do? Number one is I should be thoroughly educated and having a knowledge that when should I call this particular baby having neonatal sepsis. May it be early, may it be late, but do I have some criteria applied to this, or is it just because somebody said that this is a precious baby, so I'm applying the antibiotic, or this has been referred to me by Falana Dimka gynecologist, I will start antibiotics? No, there should be a strong policy in your unit for the antibiotic startage of this particular thing. Then when you decide to start your empirical antimicrobials or the antibiotics, you should be looking at your past antimicrobial culture sensitivity reports, and based upon that only you should be choosing the antibiotics which are to be used empirically before the investigations come back. Then we should have the heart and courage to stop antibiotics when our results come negative and they do not yield any infections. Then we need to reassess our culture reports time and again, especially a monthly meeting or quarterly meeting in a particular year is really important, because that's only will guide us the antibiotic utilization of particular unit and what sort of pattern we are observing in the microbials from a particular unit which is referring to us like that. So that's a job of bigger hospitals, especially if medical college units are looking into this particular thing. We need to also monitor the dosage and particular antibiotic levels in the babies also, because we know that the lower concentrations will lead to more antimicrobial resistance development, and lower concentration will also mean that there will be no therapeutic response also. So we need to monitor the dosage and monitor the drug levels of these particular antimicrobials in the babies also. And if we find something unusual, we need to report to our colleagues, to our state headquarters, or even the national bodies, so that something which has went wrong with you or in your unit might salvage many other newborns and many other units together countrywide. Common mistakes what we see in the neonatal prescriptions of antibiotics is that we often overprescribe. We are often going to we want to remain safe, and we want to salvage all the babies, and we want to cure all the babies of our nursery, and that leads to a fear of missing out a particular baby, and that leads to ultimately overprescribing. So please, please, please come out of that FOMO and let your unit have a strong policy of antibiotics prescription. We often prescribe broad spectrum antibiotics, and that is really harming the baby, and that also is generating the antimicrobial resistance. So be specific in that particular infection. For example, if I'm going to need a antimicrobial for staphylococcal infection, my choice should be limited towards those class of antibiotics which really strongly bet on the staphylococcus. Just like similarly, for gram-negative, we should be also choosy enough to select a class of antibiotics which give us the maximum benefit and minimum side effects or minimum drawbacks. Third thing is combination therapy. We often rely upon the combination blanket therapy. We often do not know or even guess a particular bug, and so ultimately what we isko bhi laga do, usko bhi laga do, or isko bhi laga do. So ultimately we have a blanket prescription in front of us where we have the cocktail of antibiotics going. अब मेरे को क्या पता, अल्लाह को जो ठीक लगेगा रख लेगा, बाकी की मुझे वापस दे देगा. नहीं भाई, वो एंटीबायोटिक वापस नहीं आती. Ultimately the babies are also suffering because of that, and the bug also gets a chance to develop antimicrobial resistance. So it helps nobody. Please, please, please refrain from this. Wrong doses. We often tend to either use a higher dose or underdose those things, and that leads to a lot of problems. So dosages should be proper in this particular thing, especially in the setting. We all know that for the doses which are for the term or the duration of the drug for the term, or the interval of the drug for this particular term or a preterm is different. So please stick to those things which we should be utilizing. And often there is a wrong route which is being utilized for this particular thing. We all know that the oral antibiotics do not work well, or their bioavailability is always questionable in neonates. So while prescribing an antibiotics via wrong route really gives wrong impressions and wrong results. So please refrain from those things and write it for a particularly right duration of antibiotics. For example, there is no duration calling that 5 days of antibiotic therapy will be given to this particular newborn. Either it is 7 days or it is 14 days or 21 days. Based upon those particular parameters or the disease situation, you have to modify the duration of this particular drug or that particular situation. There are principles which have been laid down in the NHS, and they called this particular campaign called Get Smart. This also having the similar principles what we have just discussed, but for your reference, I have kept this particular thing here. We need to have a friendship with our pharmacy experts. We all know that many a times if we go back into history, most of us learned pharmacy just to pass the second MBBS, and we do not know many a times the intricacy of the drug or that particular finer aspects of the particular drug. So we need to have a good friendship with our pharmacy department, and especially if a pharmacist which is well trained for the infectious disease, then he can really help us out in diagnosing the antimicrobial resistance and to formulate our antibiotic stewardship policy for the unit. We need to keep a track on our antibiotics. We need to always monitor the antibiotic utilization rate of this particular thing and how much was the response of that particular bacteria in that particular infection time zone, and then what can be more done for the quality improvement of this particular thing. So we need to rely a lot on the data of the antimicrobial usages, and unfortunately many of the units, rather most of the units, do not track their antimicrobial data very well, and most of these are often not shared with the state or national agencies. So the nationwide policy is often formulated based on the older principles only rather than the new feedbacks. Reporting is really something which requires a gut and the courage, because ultimately we are assuming that if we report something bad, people will take bad impression of us and we might lose our that gratitude situation. But no, you need to report that yes, antimicrobial resistance is erupting, yes, our antibiotic utilization is going up. Then only somebody would put their mind and brain behind this to find out what is the fault and where we need to improve this particular area. If we can improve this particular area, then only the future is really impressive in front of us. Education remains to be a most important tool, as we know that the science is the only thing which is really changing day by day and every minute. So what was being taught to us in medical colleges, many of those things are not true nowadays, and what will come up in the future we also do not know. So keeping all of us updated by various ways is really important, and we need to generate those feedbacks which will generate later on the strategies, and strategies will formulate the policies for the particular nation. That's why the education need to be continuous and ongoing, so we all can remain in this particular wave. Remember, we always talk that antimicrobial resistance erupt because of the people going to the general medical shops and purchasing without prescription drugs and other things lead to a lot of antimicrobial resistance. But he might be picking up 1, 2, 3. Here in the NICUs or the ICUs, we are utilizing for days and days together, and we are using much higher versions of the drug which are really meant to be saved for the last doomsday, and we are utilizing them haywirely. So please educate not only your colleagues but also the Jahir Janta or the general population, general public. This is one of the picture which I have posted related to that particular antimicrobial resistant thing on Twitter. And remember, we thought that the general population might not be interested, but look at the impressions this particular post received. It's 27,500 plus, and it's still going on. People are really interested. Please talk to them. Please teach your community. Ultimately, to by whichever way, if we can reduce the antimicrobial use and abuse, we can really salvage our antibiotics, and that's the message for the day. And I would like to thank all the friends here for allowing me this particular talk. And I thank NNF also for this particular opportunity given to me. I'm open to questions if you have any.
Uh, Thank you so much, Dr. Maulik. This is one of the most burning issue, and all of us must address this. Otherwise, in a month, if you are getting one or two in resistance to all, that the two or three count will increase to in a number day by day, and the day will not is not so far where you are knowing that the baby is having septicemia and you don't have any weapon with you, and in front of your eyes you are not able to survive in spite of knowing that this is the condition which we have faced in recent era of COVID. Like there were no drugs and we were all helpless with the supportive management. Then over a period of time we could manage. But however, for the antibiotic resistance, it will be a difficult era if we don't awaken up just now. Thank you so much, Dr. Maulik, for taking up such excellent session. Jatin, are you there? I think Jatin.
think-
Okay.
oh,
Kunal, you can
yes,
sum up
yeah,
the session.
conclude, yeah.
Thank you so much, Dr. Maulik.
Thank you
Thank
so
you, ma'am.
much, Maulik sir. I hope that the bacteria don't become Naya Supreme bacteria, but our doctors do. So thank you for this enlightening and presenting a bit of a boring subject in such a lucid and entertaining way. And directly it went to our heads. And hope that we all use the antibiotics very judiciously. So thank you so much, sir, for this excellent presentation. Thank you, Svetal ma'am, for being there. Thank you, Jatin, for excellently moderating the session. And I would like to thank ClearNet also for the lucid experience.
We
Thank
have Dr. Monish sir also with us.
yes. Uh, thank you, Monish sir. So last 2 months, Monish sir has excellently moderated the sessions throughout, and we are thankful to you. Officially, we didn't get the this thing, but thank you, Monish sir, for being there throughout the last 2 months. Uh, so thank you one and all the delegates for being there till the end of the session. I hope you have learned things and hope you will use all the antibiotics very judiciously. Thank you, Ritu. We can wind up now.
Thank you so much, sir, for your valuable insights. And I hope you had a seamless experience. So, with
Yes.
all your permission, we are signing off for today and looking forward to host you again very soon in another interactive session in the near future. So, till then, everyone stay safe and healthy and have a nice